Hi, I'm Mally Schansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Today, we are going to talk to Dr. Tyler Baker and discover how to achieve maximum root canal disinfection through a minimally invasive protocol. Dr. Baker will share clinical cases using the GentleWave system and show us the benefits of using this technology. Before we get started, I would like to invite viewers to use the question box in your control panel to ask any questions that you have, and those will be answered at the end of our session. I would like to introduce Dr. Tyler Baker and give a quick summary of his credentials. Dr. Tyler Baker received his DDS degree from Loma Linda University. He received an AEGD certificate and other awards while serving as a dentist in the United States Air Force. He returned to Loma Linda University, where he received a certificate in endodontics and a master's degree. He's been published in the Journal of Endodontics and other publications. He currently practices endodontics in San Marcos, California, where he runs the North County Seattle Study Club, and he was voted one of San Diego Magazine's top dentists. We now welcome Dr. Baker to begin his presentation.
Very good. Thank you, Mally, and I'd like to thank everyone for attending our webinar this afternoon. I think it's very exciting new technology we have to present, and I'm not sure how familiar everyone is with it, but I expect you will become more and more familiar with it with time. So today, plan to just kind of give more of an introduction and overview of kind of the technology and the benefits that it can provide for the endodontic practice. So here's a little bit about me and my office. I'm located in San Marcos again, and it's basically North County, San Diego. Some views of my office. I spend about 12 hours a day here, it seems, so I kind of feel I want to make a comfortable environment someplace. I really want to enjoy working, and probably like a lot of you, if you're tuning in, most of you are probably sort of tech guys. You're into something new, something that to add to your practice, keep you up to date, something that's fun, and that's kind of that's what keeps me going every day, is finding something that's new and fun for my practice, something that's going to benefit the patient. To this point, I've done quite a few GentleWave cases. I've started using it close to a year and a half ago, and probably done as about as many as anyone. And here's kind of me using it in the office. On the left, you can kind of see the GentleWave device in the background, and then you can see their instrument head being used on a patient, and you can see it's very unassuming. Looks pretty straightforward, not something real scary to the patient. Now, to go over really the intricate details of the device, we have Bob Guyette, the Vice President of Sunendo, who's going to present a little more detailed information on the inner workings of the GentleWave device.
Thank you, Dr. Baker. I'd like to take a few minutes to review the GentleWave system. I think it'll provide some context within which to appreciate the clinical cases that you're about to see. So the GentleWave system is comprised of an operating system and a treatment instrument. And on the screen you can see the console, which houses the operating system, and then on the right hand side of the console you can see the holder, which houses the treatment instrument. So for a thorough deep dive analysis on the mechanism of action, I'd urge you to visit Sunendo.com. But for the purposes of today's webinar, there's a couple of key areas I want to highlight. So let's start at looking at the primary role of the operating system, which is the ability to optimize treatment fluids. So here we see the storage area where the treatment fluids are contained, the sodium hypochlorite, EDTA, and distilled water. And the operating system is constantly measuring and adjusting the concentration levels of these treatment fluids to ensure maximum disinfection of the intracanal structure. The other way that we maximize or optimize treatment fluids is through these three cylinders that you see in the screen. So we're looking at a cross section of the GentleWave console, and these three cylinders serve to extract all of the gases from the treatment fluids. So how is this done? Why is it important? Well, let's start with the how. The how is through a process called degassing, which is simply a process of removing gases that will benefit any process where gases can negatively impact the desired outcome. Now, why is this important? It's because we know that gases in conventional root canal therapy manifest often as vapor lock in the apical third, where the vapor lock prevents the disinfecting fluids, the treatment fluids, from reaching the apical third. We also see it in the coronal and middle third, where the gases that are contained in air bubbles in the canal end up insulating the bacteria from the treatment fluids. And the end result is an unacceptable level of canal cleaning with conventional root canal therapy. And so with the GentleWave system, the ability to optimize treatment fluids by completely degassing them works as part of the broader mechanism of action that's delivered through the treatment instrument. So the treatment instrument takes the degas fluid and it applies multisonic energy. And this multisonic energy then is submitted through the very complex anatomy contained within a tooth, and it's able to identify the natural frequency of the complex tooth structures contained within. So the degas fluid working in synchronicity with the multisonic energy completely debride the intracanal tooth structure, disinfect the tooth structure, including deep into micro tubules, dental tubules, and it also does this without requiring any removal of precious intracanal tooth structure. So let's take a look at how that manifests. So here we have a cross-section of calcium spheroids. This is dentin in its native state, and we can see cleaning with the GentleWave system, and this is an area that's never been touched by files. So we are able to maintain preoperative tooth morphology. Clinicians are able to use files as small as a 1504 if they desire. And we're seeing patients that are not having much post-op pain, and we're seeing fast healing. Here's a 2000x magnification, and here's a 20,000x magnification where we see tubules inside tubules. So with that, I'd like to hand it over to Dr. Baker.
Great, thank you, Bob. It's kind of those areas where a new technology, it's very important for the user to know exactly what it is we're doing. And so I'm going to kind of show, I guess, the effective portion or the treatment sort of head of the GentleWave device. And basically what we have is a sealing cap that sits over the top of the tooth, basically making a closed system for the GentleWave to work. And then what happens is our treatment solutions travel down this tube and hit a concave plate at the end of the tube, and in effect produce what is called a cavitation cloud. And this cavitation cloud produces little cavitation bubbles that implode, and in the process produce little microvortices of different wavelengths of energy that travel down the canal. And this energy works to effectively break up debris, vital tissue, necrotic tissue, and biofilm, and remove it from the canal. Again, what's important to note that Bob showed in the mechanism of the GentleWave is that, one, the solutions are all degassed. If you've seen microscopic views of irrigating devices cleaning these small channels, what they have found in their studies is, again, the little bubbles in the canals serve as almost pillows where these energy waves traveling down the canal will hit one of these pillows or bubbles and effectively reduces that energy wave from propagating down the canal. So if we can eliminate those gas bubbles by degassing the solutions, it makes those energy waves much more effective. Likewise, these solutions aren't just injected straight down the canal where they can potentially drive solution out into the apical tissues. The whole time this solution is being evacuated from the system, so you get basically energy waves traveling down the canal, but the solution's effectively constantly being pulled from the canal system, so that it's a very safe and effective mechanism of action. Now, at the AE, we'll be going through some of these in much more detail, but this I feel is a good overview to understand what it is we're doing with the GentleWave device. Now I'm going to move forward. Let me get rid of my little pen here. And so here are some classic cleared teeth that have been injected with dye to show the complex anatomy of a tooth. And you know, these are some of the first studies that we've done to illustrate the complex anatomy of a tooth. Now we've kind of gotten into micro CT scans, which are awesome for us to more thoroughly visualize the complex anatomy of a root canal system. But what this also illustrates is what I feel is the ideal root canal. Really, if you see, I'm going to grab my, I guess you can, maybe let me grab my pen again just to show what it is we're trying to illustrate here. Basically, an ideal root canal consists of a very small access opening, and then if we could effectively clean out the full canal system, debride it of all tissue and bacteria, and basically inject our filling material down the roots, filling the chamber, basically leaving the anatomy of the tooth, all the dentin the same, while effectively fully sealing the canal system, that would be an ideal root canal. And so moving forward, this is our goal in root canal treatment. But I feel like we've kind of hit an impasse when it comes to our root canal treatments. We've kind of come to a point where this is kind of the standard of care. Now, how did these look in any way similar? They don't, but I mean, there is rationale as to why we do things the way we do, but I feel we've kind of hit an impasse. Again, we're basically doing things the same way we did 60 years ago, or whenever, or even 100 years ago when root canals were initially started. Basically, we're still using an instrument to auger down the center of the canal, removing dentin and filling it with a filling substance. These days, we have quicker methods of doing it with NiTi files, but it's basically the same system, and then we're basically, filling with a cone of gutta-percha. So, you see one of these root canals, and this was done by someone who was probably very skilled. And what's interesting is this is a case that I happened to even treat this morning, where the root canal looks very nice on the x-ray, but there's an apical lesion, and these kind of treatments still fail today. Here's an interesting study that Paik did in 2009, and on the left in image A, you can see the natural complex anatomy of a mesial root of a lower molar. Now in figure B, you see the instrumentation pattern of a ProTaper F3. Now this could be any instrument, not just a ProTaper. This is the natural instrumentation pattern that we get. Now, if you place them over each other, you can see the instrumentation pattern misses two apical foramen and a large fin. Now, we instrument this large because the goal is to get our irrigants down to the apex effectively. Now, what's interesting about this study is the process of instrumenting filled all these fins and lateral canals and ramifications with debris. Now, once we irrigated, the study showed that only 50% of that debris is filled. And, common sense would make you think, okay, if I instrument to a 3006, in some cases, we're instrumenting size 50 and larger, to effectively clean the canal. If that's the case, we should be seeing tons of lateral canals because we are just flushing it so much more effectively. But what's interesting is we tend to see the exact opposite. The more we instrument, it's interesting that the less anatomy I tend to see in my practice. And so I'm going to illustrate some cases today that I feel kind of drive home a little bit more of what we're trying to do. I feel it gets us back more to that image on the left, where we're conserving and preserving the natural anatomy while more effectively cleaning the tooth. And I'm going to start by, again, today I'm going to show the straightforward cases, the ones that should be just a walk in the park. You're thinking, hey, there's a slam dunk, there's a 20-minute molar, there's money in the bank. And what's interesting is you've all had cases where, you had one patient complex curved canals, calcified canals. You pulled the heroic move, you instrumented the canal, it turned out beautiful, and then you had the case like this, you instrumented it, and for whatever reason, this patient came back. They had the apical lesion that returned, they had the continued symptoms, and you're thinking, now I did that complex one, why did this easy one come back and fail on me? And this was an 18-year-old boy who was seen by one of my referring docs. Patient came in pain. The referring doctor removed the occlusal decay, did a pulpotomy, and sent him over for me to treat him the next day. Now, if you look at the root canal system on this again looks pretty straightforward. Now, what would most of you instrument this root canal to? I'm going to guess the distal canal. I would see on average anywhere from a 30 to a 50/06 instrumentation pattern. And in the mesial canal, maybe a 25/06. Some of you may take it a little bit smaller, but on average, as we were taught, to effectively irrigate the canal, based on Cotomi's study in 2006, most of you would instrument to 30/06 to make sure you're properly instrumenting this. Well, this is one where I actually instrumented to a size 15/04 in every canal. Now, I think most of you think, well, that's kind of crazy. Why would you do that? And it's because of that last study that we saw, in which case this anatomy can be very complex. And so over-instrumenting the canal can actually block you out of a lot of these fins. And if we use a smaller instrument to brush and work our way into the main areas of the canal without effectively taking away over-instrumenting the canal. Basically what we're trying to do is preserve the natural dentition while removing the debris, but if we over-instrument, we're going to pack a lot of that debris into the eccentricities, and our irrigation patterns are going to be less effective. So what we're getting to is multiple apical foramen, which looks a lot more like image A versus image B, where we would have, in general, one large cone in the distal root and two large cones in the mesial root, and a lot of times those little apical ramifications and fins would be unfilled. I'm going to move on to the next case here, and again, this is another fairly straightforward run-of-the-mill case where a patient presented with irreversible pulpitis. Now, the canal system is fairly straight, maybe a little more constricted than average. And I'm going to jump forward to what I did in this case. Basically, starting at the top of the canal, maybe a little larger access than what I would like to see on average. For some of you, this may be bigger. For others of you, this may be smaller than what you do on average. For me, I made it this size so I could effectively remove that pulp stone from the pulp chamber. But if you see the image on the right, we've still preserved the natural pulp chamber size. We've pretty much kept the anatomy exactly the same. Now, if we zoom in on it a bit, we've still effectively fully cleaned the canal. We've cleaned the webbing in the mesial canal. We've effectively cleaned a lateral canal. And we found multiple apical foramen. Now, for most of us, in order to fill this kind of anatomy, what would we do? We would instrument the canals, and then, in general, we would place calcium hydroxide in order to give our irrigants or our cleaning medicaments more time to work and break down that tissue. Some of you would let the sodium hypochlorite sit for 30 minutes. Well, this is one, again, where we did very minimal instrumentation technique, but with the GentleWave we were able to effectively irrigate and debride and clean the canals. And again, there's those out there that feel that small shapes can't be filled effectively. Well, they can. Basically, using similar principles to what we already use, we can effectively three-dimensionally fill the full canal system while maintaining the original canal anatomy. And I feel this is going to be a much stronger and much more of a long-term option for the patient over what we're already doing. Now I'm going to move on to a case of mine. This is a case that I did about 6 months prior to using the GentleWave. And this was an upper molar number 14, not number 13. Hope I'm not that bad on some days, but number 14, basically what we did here is we instrumented 4 canals. The MB1 and MB2 canals kind of joined at the apex. We medicated it with calcium hydroxide, had the patient back. We irrigated copiously. We used the endoactivator to agitate and more effectively clean the canal system. But patient returned to my office about 9 months later, and I believe all of you can relate to this situation again, where patient came in, I tap on it, it doesn't feel right, and she was even more specific, where she said, hey, if I bite on the mesial buccal cusp of this tooth, it doesn't feel right. I can tell it doesn't feel right. Darn, this is one of those where, what's going on? Looks good. We filled to the terminuses. What did I do wrong here? And this is kind of one of those where, those on the other side of the table doing implants would say, hey, these are the ones where root canals don't work. Have you, they love to ask the audience, how many of you ever had a root canal? How many of you can say it hasn't felt quite right? Well, this is one of those. And if this patient happened to see a periodontist or someone else, not that it's a periodontist, but someone else that's pushing more of an implant-based practice, they may say, hey, this is the best root canal that endodontics has to offer. Really, if you want this to work, you should take it out and do an implant. And what's an interesting study that just came out of Toronto and showed, there's a couple preferences. Number one thing that patients want is to be informed of all the treatment options. So, definitely want to inform them of, hey, we could take this tooth out and do an implant. But likewise, the number two thing that patients are looking for is they want to save their natural teeth. So we want to do everything we can to ideally save that tooth. People have an emotional bond, and it's not until something breaks that bond, failed root canals, a history of failures, someone, pushing more of the implant scheme and things, that people get dissuaded away from the tooth. So anyway, moving on, this tooth, patient was symptomatic. So these days, what are we going to do? We're going to take a cone beam. And if we look at that mesial buccal root, we're seeing a small radiolucency in that area and what looks to be a little apical bifurcation. And I've seen these a fair number of times, as I'm sure some of you out there have. And what's great about the cone beam is you can measure right down to that bifurcation, and a lot of times you can find your way into it to instrument it. But this was a case, I went back in to re-instrument the canal. I just could not get into it. It was just that lateral canal, it was just not happening. So, we went in, irrigated with the GentleWave, and what did we find? We found a lateral canal in that area that we weren't able to pick up, no matter medicating the canal, no matter how long I irrigated with the solutions. We weren't able to find it. And so after this, the patient's symptoms subsided. It's amazing how one of these little lateral canals is the difference between patient being fully functional in a quadrant versus not functional at all. And some people don't get real excited about lateral canals. They don't think it's important. But this is something that I do see as a continuing symptom that patients come back with, and this is the kind of thing that gets bad press. I'm sure a lot of you have seen the patient that comes in and says, hey, root canals cause cancer, root canals leave bacteria in my mouth, I don't want bacteria in my mouth, I want an implant. Well, this is something, since I've used the GentleWave, that actually happens quite frequently. I don't want to be the one that shows my one case where I picked up a lateral canal. This happens all the time. When I first started using the GentleWave, all of a sudden I started picking up these little lateral canals in the mesial, these little apical bifurcations. I started to wonder, is this something I need to be looking for on a daily basis? After I find that small MB2, do I now need to be putting little bends on my files and finding my way into these little apical bifurcations. And how are you going to predictably find that? You just can't. And so basically, we need a more effective way to clean the tooth, and that's where we're at. We're looking for ways to preserve the natural shape and anatomy of the tooth, the full tooth structure of the tooth, while more effectively cleaning the full canal system. And so, you know, in conclusion, basically, this is more holistic, this is more natural, this is something that patients can relate to. It's preserving the full dentition of the tooth, the full tooth structure. This is minimally invasive. This, while we're still cleaning the multiple eccentricities of the canal. And, you know, something I think about when I'm working on a tooth is, you know, really the true test of a man's character is what he does when no one is watching it. Endodontics is very easy to do a very basic job on, and no one will know the difference. You can easily fill 3 canals, stuff it with a cone of gutta percha, and a lot of people would not know the difference between that and this. But what it does show is the test of time. And patients know when it doesn't feel right, they know when they have to return for a redo, and the referring doctor knows when it fails, because when they put the crown on and it's not feeling right, they're going to send it back to you and they're going to tell you that tooth's failing because of your endo. And I feel this is something that, you know, needs to be addressed, and we need to take that next step towards moving endodontics in a different direction. And so this is something that we're going to stress a little more at the AE convention, GentleWave. This is kind of their passion and what they're looking to achieve, and that this is just kind of hitting the surface of what we're doing. And I hope you'll join us for future sessions of either these webinars or meetings at the AE, because really we are pushing endodontics in a different direction, and it's fun and it's exciting because we can see it in the patients when they return that we're doing something that is going to last, and they're going to be much more comfortable because of it. So I'm going to turn it over to Mally again if there's any questions in particular that people want to ask.
Yes, I would like to remind people that you can ask any questions now in your question on your question box in your control panel. But I do have a question, and thank you so much for that informational presentation. I really enjoyed it, and I know our viewers are too. My first question is, why did you incorporate GentleWave into your practice?
You know, for me, you know, again at the beginning, I kind of stressed that I am into new kind of fun stuff to keep the practice exciting. But before I incorporated, well, what's interesting is we're getting into a lot of people are getting into the minimally invasive instrumentation technique, and I think it's fantastic. But what we need along with it are more effective cleaning techniques to go along with it. And I noticed we're still lacking in some of our debridement techniques. And I was, even thinking of buying a used laser. A lot of the studies out there show that some of these other cleaning methods aren't as effective, but I was still looking for something new that would be more effective in debriding and cleaning the canal system. And it just so happened that at the same time I was looking, GentleWave and Sun Endo's company happened to be close by, and it happened to be something I was looking into. And after looking into the technology, it just sort of made sense to me. And it's something that's developing, and I'm sure a lot of endodontists are like me out there who, they're skeptical of new techniques, and it takes a lot for you to change and make that next step into something new. And for me, after playing with it and trying and, looking at extracted teeth, it's something that all of a sudden, it really did hit home that I'm doing something better, new, something that that is going to improve the outcomes in my office. And so, that's kind of where it came in my personal situation.
So, as a result, do you feel that you are now providing a more efficacious root canal treatment?
Yeah, exactly, and that probably goes along with my last treatment. But one note to go along with a more efficacious treatment is, sometimes people think that a new irrigation method will be much more traumatic to the tissues around the tooth, and so the thought initially is, hey, this is going to cause more post-op pain, and you see it in your referring offices where they say you get a few of those questions. Hey, this patient has post-op pain. Was it because I irrigated too much with bleach? And usually it's the opposite. It's because you didn't irrigate enough with bleach. And with the GentleWave, because it so effectively debrides the area, I actually feel like I see a much less post-op sensitivity in vital cases as well as necrotic cases. I feel it more effectively cleans and pulls bacteria and toxins from the apical tissues and from the canal system, that I am actually seeing much less post-op sensitivity, much more comfortable patients afterwards. And so that's where I'm seeing most improvement.
How have your referring GPs responded to GentleWave, and has the number of your new referrals increased?
Yeah, the first part is GPs and referrals. What's kind of interesting in the referral patterns is the patients even. It's interesting. They notice a difference. They see the less scary, the less traumatic a method in which the root canal was performed, and they note that they have less discomfort, and they see in the end how well the root canal went, and they tell their friends even that hey, this was a better method. I forgot the first part of that question again, if you don't mind repeating
how have the referring GPs responded to the GentleWave?
And the ones that really matter are the ones that do quality treatment. They're the ones that tend to notice the most. The guys that spend the time doing the quality crown preparation and restorative work, the ones that care, those are the ones that notice. And usually those are your best referring docs. They know that the endodontists, that's what they do all day. They're going to refer the patient for that, and in return they see it coming back. They look at the treatment reports, and so really I'd say I've noticed it in the quality referrals. They see the better result, and in turn you see a better referral pattern. So that's where I tend to see it.
How have your staff adapted to this technology?
They think it's fun. It's something new. Some offices, some staff, they're gonna see it as, oh man, I got something else I got to deal with. But it's actually a fairly easy system to use. With it functioning in the cart, it's easy to just kind of plug and play, so to speak. You just roll it into the next room, plug it in. It's got the touch screen, so it's easy just to flip through it, and it's all in kind of a self-contained device. So when it comes down to it, it's really not a complicated issue for the staff to deal with. And again, it's fun for them to kind of see a better result as well.
I think you addressed some of this question. Are you saving more teeth with this technology?
Yeah, I'd like to definitely say so, especially that last case. That's kind of one where it may have ended up with an apico. That may have saved the day, but we were able to preserve more tooth, more minimally invasive. I feel it has a better long-term outcome. So I think we are saving more teeth.
Okay. Are you seeing faster healing, and if so, why do you think that is?
Again, the old saying is the reason infections persist is inadequate debridement, and that's kind of what we see with this, is a better debridement of the lesion. The canal system should allow for much better healing, and some of the studies you've seen the JOE and that will present the AE, a variety of quality clinicians, a variety of our endodontic schools have done some quality studies on the healing, and with time they'll be seen in the papers. I even sent into, when I first started visiting them, you could see the quality of the research they were doing, randomized control studies, just high quality studies that take a lot of money and take a lot of time. And so I think some of this is something that's going to play out more in the future in the studies, but clinically, having used it for a year, I don't have any specific data on that, but at this point, I can see it is effective.
Okay, we do have a question. Somebody just said, "Nice cases, Doc. From all of these cases done with GentleWave, did you prepare the root canals with NiTi files first and obturate with Mastercone GP?"
Yeah, yes, NiTi files. The one advancement I feel in NiTi files is the flexibility and our ability to instrument with a much smaller size. And then with that being said, then we can kind of come back in with the GentleWave. The old idea of doing a big access to get our straight line access to the apical third, the file companies have greatly improved our ability to instrument without having to over-instrument the tooth. And so that's kind of played right into the GentleWave and being able to effectively clean those tough-to-reach areas. And yeah, I use master cones in some cases. It's a variety of techniques, but it's basically some gutta percha cones, some warm gutta percha techniques, and it's something that I feel is kind of a longer discussion for later, because I don't want to say too much that may get someone in trouble trying to be overly what's the word, just overly aggressive in obturating three-dimensionally. But there are consistent and predictable ways of three-dimensionally cleaning filling the canal system with gutta percha. So, but thank you very much.
So how has your filing protocol changed?
It's much smaller. For me, the aha moment came a few years ago. One of my GPs told me I did root canals like an endodontist. What does that mean, I do root canals? Is that a compliment or a dig, or what is that? And basically he told me I make the big instrumentation in the canals, and I was kind of like, you're exactly right. I do feel like, from what we were originally taught, everyone's natural inclination, when the first time you ever did a root canal in dental school, you probably did a super small access, and you were very proud of finding the canal through a small access and a small instrumentation, and then your instructor told you, hey, you need to open up this much bigger and instrument bigger. And so, being told that by endodontists over and over, you start to buy into it. But really, I feel like we kind of pushed too far in that direction. And what's great is some of the new instrumentation and obturation protocols really allow us to stay small. And so, a number of these cases were 1504, but a variety of them, I don't advocate one file over another as long as it has a small diameter, because, or it basically, I basically look to mimic the canal size. That's really what my goal is. So there's V-tapers, there's a variety of fantastic files that I feel mimic. However, when you go to AE, you'll see a million different files, and quite a few of them are mimic of larger filing techniques and one file techniques. Well, a lot of times I am doing a one NiTi file technique, but it's a very small file, and again, it's much less invasive, and it's preserving a lot more tooth structure, and it's much more fun to see the final results. So Again, a lot of these are kind of deeper discussions for kind of another time, but that's kind of a short answer to probably something you're wanting to hear more information about.
We're getting a lot of questions in. Somebody said, great presentation. Have you noticed limitations or contraindications with the system, and how could this be used in practices with multiple offices?
You know, limitations, at this point, it's limited to molars. You know, there's certain cases where just kind of the orientation of the tooth, you know, certain extenuating circumstances maybe don't lend itself ideally to it, although, you know, most molars you can use it to a greater or lesser extent. There's going to be advancements along the way. So at this point it is kind of a molar technique, but you know, as far as multiple practice offices, I think it, because it is kind of more or less an 8-minute treatment time. Basically, you're irrigating with sodium hypochlorite for 5 minutes. Then it does a 30-second flush with basically sterile water. Then you irrigate another 2 minutes with EDTA, and then a final 15-second rinse with sterile water. Basically, after that 8 minutes, you can easily unplug it, roll it to the next person in a multi-office practice. I can't imagine everyone can't use it in a multi-person office. And again, it probably needs to be seen in practice, but you know, a 2-3 doctor office, I don't see that being a problem.
Okay, we have somebody who entered the seminar late and was interested in finding out how the GentleWave works. So I would like to say to that person, since we're coming to the end of our webinar, that we will be sending you a recording of this presentation, so you'll get a chance to catch up when you see our recording. We did have a question about price ranges, and so the answer to that question would be, please go to sonendo.com for more information, or to email them directly at info@sonendo.com, and you'll find some more information. I don't see any more questions right now, but in closing, I wanted to thank you, Dr. Baker, for a wonderful and informative webinar, and I invite our viewers to visit www.gentlewave.com and www.sonendo.com for more information. Sonendo will be at the AAE in San Francisco, April 6th through the 9th, so please be sure to visit them at booth number 317. That's booth number 317. In addition, Dr. Baker will be presenting at the AAE on April 6th at 10:45, so you can meet him in person. And please download the attachment on your control panel for your reference. Again, thank you so much, Doctor, for the webinar. We thank our attendees for attending. We look forward to seeing everyone at the AAE. Dr. Baker, would you like to say goodbye to our viewers?
Exactly. Thank you, Melly, and I'd like to again thank everyone for attending. And again, there's much more to the GentleWave system that can be incorporated into the practice and the way we're doing things. And I feel it's really a new and exciting change that we haven't really seen in endodontics almost since the beginning. You know, just a totally different way and approach to root canal treatment that I feel is really going to be exciting for the future. So again, I would like to stress people to come to the AE as well and come see our future lectures, because it's going to be a fun and exciting way of doing things. So, thank you.
Thank you.